All right, good morning. I'm with the pleasure to introduce Ajay Ramnot. He is currently one of our spine fellows. Ajay earned his Bachelor of Science in Biology at Florida Atlantic University in Boca Raton, followed by his Doctor of Osteopathic Medicine at Nova Southeast University in Fort Lauderdale. He is a couple of interesting things about his residency. So his residency, he did at Arrowhead Regional Medical Center, which is in California. Two fun facts about Arrowhead is actually it is designed to withstand an earthquake of 8.3, which puts Harborview to shame that is not even rated for earthquake safety. So in case of an earthquake, you rather want to be close to that place. It's also the second busiest ER emergency room in all of California. So very interesting. So a very busy place that he did his residency in. AJ has published and presented nationally in spine and cranial surgery, and today is going to talk about the transformative role of artificial intelligence in spine surgery. So AJ, we're excited to have you here, and yeah, tell us everything about it.
Thank you, Dr. Ostead. I appreciate that. And it's really a pleasure and an honor to be addressing you guys and speaking at your grand rounds. It's been here for 2 months, and it's been a fun 2 months. Harborview is a special place. All righty. Okay, so today we'll talk about AI, the practical implications of it. But before we do that, we'll really look at a brief history of AI, where we came from, go through a few definitions that are pertinent, talk about predictive models, really a couple models put forth by Dr. Ames at UCSF in adult spinal deformity. And then just look at future directions. This field is really wide open in terms of where we're going. So brief history, the first musings of artificial intelligence was when McCulloch and Pitts put forth the MCP neuron. And this was actually modeled after a biological neuron in our nervous system, where you have multiple inputs from the dendrites, and these inputs have different weights to them that feed into the soma of the cell or the node, and then feed the output out to an axon. And then there's also forward propagation and back propagation that happens as well. But this was the first time that the thought of artificial intelligence really reared its head in 1943. And then, of course, one of the most famous AI scientists, Alan Turing, in the 1950s, he didn't coin the term artificial intelligence, but that term came about at Dartmouth in 1956 after a meeting with very early AI scientists. But Turing is famous for many reasons, but he was also a code breaker during World War II, where he helped the Allies decrypt codes from the Axis powers. And then Joseph Weizenbaum at MIT created ELIZA in 1966, which is the first chatbot simulating anything close to what we all know as ChatGPT. It simulated a therapist that was able to display empathy to humans. So we've had something like ChatGPT since the 60s. It's quite interesting. AI sort of fell into a winter because the technology, quite frankly, couldn't keep up with all the promises that was happening that was coming about in the 60s and 70s. But then it came back to the forefront in 1997 when Garry Kasparov, the world champion of chess, was defeated by IBM's Deep Blue. And this is a picture of that match. And later on, he gave a TED Talk in 2017, and he said, when I sat down at the chessboard across from Deep Blue, I immediately sensed something new, something unsettling. I couldn't help wondering, was it invincible? Well, yeah, in 2022, ChatGPT was launched, and it's quite impressive, but definitely not invincible. Anyone who's used ChatGPT knows that it's prone to what's called hallucinations. So somebody fed it this prompt, and what's the world record for crossing the English Channel entirely on foot? And while Christoph Wondrasch did cross the English Channel in record time, he didn't do so on foot, which is impossible. But you see that AI is susceptible to what's termed hallucinations, where it'll mix factual data with something it's just making up for the sake of completing your prompt. And anyone who's used these large language models knows that you have to watch for this and cross-check it. And if you're doing sensitive work, it's probably best to use a higher end model, one that's not prone or less prone to hallucinations. I like this graphic because it really summarizes artificial intelligence starting in early 40s, showing the work that Turing did. And this was just a few fringe data scientists that did good work, but no one really paid much attention to AI until it became popular in the popular use in use of finance and economics and some medical purposes. But again, there was an AI winter that happened where the promises and technology weren't able to meet. And then we picked AI back up in the last 10, 15 years or so. So much to the point where it's widespread, and now you have people being fired over AI and lawsuits happening. And I like this graphic because it's only about 80 years. This is the span of one human lifespan. So a lot has changed in just a short period of time. So just bear with me a few terms to just go through that'll make this a bit easier. Artificial intelligence, the capability of a machine or computer to do tasks that normally require human intelligence, such as learning, reasoning, problem solving, perception, use of language, and ultimately decision making. And modern AI systems are using data-driven approaches such as machine learning and deep learning to make improvements to this over time. And really AI, artificial intelligence is just a catch-all term for a lot of what we're going to be discussing. Machine learning uses algorithms that let this computer learn from patterns of data and make predictions without explicit programming. And you can take that a step further and look at deep learning, which is a branch of machine learning that uses multi-layered neural networks to learn complex things and power things like speech and image recognition. And deep learning is a lot of what we'll be talking about today with these predictive models. Neural networks, computational models that mimic artificial neurons that also learn complex patterns. And these neurons are given a weight to them. And then the weight then puts forth an output that again is back propagated, forward propagated. And there's a lot of interplay between these layers. And that's what is termed the neural network. Very similar to how our brain works. This allows for things like computer vision that allows the machines to process data for images and video. And then large language models are AI systems that use deep learning, and they're trained on vast amounts of text, millions of books and research articles that the computer can process quickly. And then you can build a large language model like a ChatGPT or a Gemini or one of these chatbots that we've been using. And anytime you see an AI integration like on YouTube or something, it's likely a large language model that's being put forth. And then robotics is an offshoot of AI. It's an interdisciplinary field that builds and operates robots that are capable of sensing, processing information, and acting in the physical world, either autonomously or semi-autonomously. So really, for AI, there's entire degrees and curricula that are dedicated just to the development. And I'm by no means smart enough to explain all of this. This is really high-level mathematics that people use to build these models. But if you want to do a deep dive into it, 3 Blue, 1 Brown YouTube channel has a lecture series on machine learning and large language models that he does his best to break down, but even then you'll be pausing these videos and maybe rewatching them a couple times. But they are really good to gain some foundation if you want to dive deeper into how these models work. And this is a good depiction of a neural network. You see tons of interplays between these nodes and the different layers. And the more layers you have, the deeper it is, and hence the term deep learning. So question to think about is, how much AI do you already use? Probably quite a bit, and we don't even know it. It's already present in aviation. Some pilots estimate that 95+% of flight time is done by the computer. Really, only the takeoff and the landing is done by the human pilot. But even more than just the ability to fly the plane, coordinating landings and takeoffs between airports and in different routes. A lot of that is being simulated by computer models. Ground transportation is the same. Self-driving cars and traffic models and GPS are all using some sort of AI. In medicine, colon polyp detection was put forth in 2018 by Wang and colleagues, where they use computer vision to detect polyps. They trained the machine on colonoscopies, and they were able to detect polyps in all different types of conditions. You see the green outline here that's pretty faint is a polyp, and these machines are able to detect polyps in inadequate lighting conditions, very subtle polyps that aren't too distinguishable based on color. Even when the patients haven't used or haven't done an adequate bowel prep, these machines are able to still detect polyps. And they can detect polyps with about a 95% plus accuracy rating, which is on par with a gastroenterologist. So at minimum, it's just a second set of eyes that a GI doc can use while he's doing a colonoscopy. And at best, it can sometimes be better than what the colonoscopist can detect. We're already using AI in our EMR implementations. The sepsis bundle in Epic is actually AI driven, and that's been studied and it has its own critique. It's about a 60% accuracy rating for implementing correctly, but it's a work in process. And things like DAX or the ambient listening, to where you can set your phone down when you do a patient interview, and then at the end of the interview, it's recorded everything, processed it, and formulated your note that's ready for review. So these are things that are already in the world right now, and we're using AI whether we know it or not. And I think in the future, commenting on AI will be like commenting on electricity. How often do we really think about electricity unless the power goes out? I think it'll be a seamless integration. And talks like this will be in the bin of antiquity sooner than we think. That's my prediction, at least. And I'm basing this just looking at electrical usage from the 1900 on up. When electricity was first coming out for residential usage, people were actually afraid of electricity. It was causing fires, electrocutions. And the same way we have fear about AI right now, we had similar fears about electricity. But you see, really, it follows a gradually then suddenly trajectory with these type of things, because you might be afraid of electricity, but if you see your neighbors using electricity, it's probably safe, and you're going to start using it too. And then comes a power grid and things like that. Okay, so that brings us to spine surgery and AI. And this is really based on surgical optimization, patient safety, and saving the patient, surgeon, and the healthcare system time and resources is the main driving force for utilizing AI. And the way this is done is it's just sifting through data to find meaning in it. Because if a human can process, let's say 10 variables, these machines can process 100, 150, 200 variables of things we're not even thinking of, like a patient's sodium level. How would that be related to spine outcomes or their starting hemoglobin? You can think at some point, yeah, it does make sense, but for a human to sift through all this data and try to find the meaning in it, it would be time consuming, and we frankly wouldn't do a good job at it. This is where the machines are able to make a meaningful impact. And we see this gradually and then suddenly concept. If you just search artificial intelligence spine surgery, you see for a long time, there was not really much published. And then you have this takeoff. So gradually and suddenly is the way I predicted this will happen. So when evaluating models from a scientific and research perspective, the same way we have to learn statistics to intellectually talk about these things, we have to familiarize ourselves a bit with some statistical analysis. Area under the curve is similar to p-value, to where you want to know what a p-value is, and it's important to use it as a screening metric to see if there is statistical significance. But of course, p-values can be hacked, right? Meaning you can juke the stats and make your p-value look more impressive than it is. So it's a good metric for screening to see if this is a good piece of research, but it's not the end all be all. You'll want to rely on things like the Breyer score, decision curve analysis, internal validation, especially for machine learning. The way these data sets work is usually you have an 80-20 or 70-30 split of the data, to where 70% of that data is used for internal validation, meaning refining the model. The model is training on this data, and 20% is used on the test to really see how valid this model is. And then the gold standard for evaluating these models is external validation. Can you create a model in California that they're using in Switzerland, right, on their data set? And that's what external validation is. And that really applies to the supervised learning models, but we'll look at one unsupervised model, and then cluster strength is what matters in the k-value. So this can be a lecture onto itself about the statistics behind AI research, but just some general terms to be aware of when you're reading these articles. So the first paper we'll look at is a paper put forth by Dr. Chris Ames at UCSF, where he developed a computer model to predict pseudoarthrosis. And this model was able to predict with 91% accuracy the rate, looking at about 336 spinal deformity patients. So it was a retrospective analysis using a prospectively maintained adult spinal deformity database. And he looked at 82 variables, and 21 of those variables were used for model building. And the patients were dichotomized into two main groups using the Lenke radiographic classification for either union or pseudoarthrosis or non-union. And from this model, they found a 91% accuracy with 0.94 area under the curve, meaning it's pretty valid from an area under the curve perspective. These are the patient demographics that they looked at with these patients. Again, about 336, 230 in the union group, about 100 in the non-union group. Roughly the age was around 57, slight female preponderance. And it's no surprise that smoking was statistically significant when it came to the rate of fusion, right? We all know that intuitively, and that's been proven time and time again in the data. And they also looked at the type of coronal deformity as well, whether there's no deformity, a thoracic deformity, no coronal deformity, a thoracic lumbar, or a double curve. And then they looked at health-related quality of life outcome measures that we're all familiar with here. And then the typical radiographic parameters that are used in adult spinal deformity were assessed, and the ones that were statistically significant were ones that have been proven time and time again: the SVA, pelvic tilt, pelvic incidence, minus lumbar lordosis. And these are the metrics that the machine was able, or the model was able to crunch. So if you were undergoing a revision procedure, you had a higher risk of non-union with statistical significance. The most important metric that they saw was LIV is the lower instrumented vertebral level. So constructs that ended in the lumbar spine had a higher incidence of non-union as opposed to ones that ended in the sacroiliac portion of the spine, which intuitively makes sense as two AI screws are bigger screws, more cortical bone. And again, we intuitively know this, and a lot of literature has supported this as well. Use of BMP was significant. And then the diameter of the rod played a role in whether or not a patient fused or not. And anything above 5.5 had a higher rate of fusion as opposed to anything less than that. Notably, the type of rod material did not play a factor in this. And if patients underwent decompression, that also played. If they underwent decompression and the amount of decompression that they went with respect to levels also had a significant role to play in if a patient was fused or not. And then the machine was able to rank in order of importance the factors that went into union versus non-union. And at the top was the lower instrumental vertebral body. And second was the use of BMP, and third was the max coronal Cobb angle. So limitations of this study, it is retrospective in nature, which comes with its own inherent biases. They also split the Lenke model, which we see here. It's typically ABCD, and they just dichotomized it to union versus non-union. So splitting the model does create its own set of limitations for this study. And this study was not externally validated as well. So it didn't meet the gold standard criteria for an AI model. Then a few years later, Ames put forth a different type of model where he used unsupervised learning. And the goal for this was to create a different classification system where he looked at deformity not based on radiographic characteristics, but patient characteristics. And he was able to create 3 clusters of patients: young patients with coronal deformity, old patients who have never had a deformity surgery, and old patients that did had prior deformity correction. And he wanted to, this model was used to look at their complication rates as well as their outcome measures, the self-reported outcome measures. And then he also created a cluster based on the type of surgery that they had, the type of, if it was an anterior approach versus posterior, the type of osteotomy, if one was performed. And that created 4 different surgical clusters. And this was represented with a dendrogram, which we'll see on the next slides. So the outcome measures, just looking, they were gathered preoperatively, 1 year, and postoperatively. And the metrics that were gathered were gender, height, weight, the spinal pelvic parameters, and then the self-reported patient outcome metrics that we're all familiar with. And then the surgical parameters that were investigated were presence of previous spine surgery, any major complications being need for revision from PJK or any type of hardware failure, superficial or deep wound infections, things like that. Surgical time was evaluated, blood loss, the number of levels as well, presence of pelvic fixation, presence of interbody fusion, and then the type of osteotomy, if one was performed or not, between no osteotomy, Smith-Peterson, and 3-column osteotomy. And I know this can look a bit confusing, but it is a new way of looking at data. This is a dendrogram. Well, I shouldn't say new way. Dendrograms have been around for a while, but at least in this model, the way this works is there are 3 clusters that are present. So the blue represents young coronal patients, young being defined as patients around the age of 47. Gray is older patients around the age of 61, 62 who have never had a spinal deformity surgery, and then old patients who have had spinal deformity surgery in the past. And the way this works is each patient is assigned a number, but the closer they are to the periphery, the more related these patients are in the cluster themselves. So these patients are more related to each other, as opposed to patients that are towards the center, where they're more related to the other clusters, right? So this gives some patient individualization. And this is a gap statistic that looks at, because how do you determine how many clusters you have? So a gap statistic of 0.67 at 3 clusters indicates that 3 is the appropriate level of clusters to have for this model. And then the different p-values and statistical significance for these different metrics in the patient-specific clusters, previous spine surgery, the age, spinal pelvic parameters, and their outcome metrics that they fill out. And then this dendrogram looks at, there's 4 clusters here, and these are the 4 different types of surgeries that are performed. So blue represents patients that have had 3 column osteotomies. Yellow is no osteotomy and no interbody fusion. And gray represents patients who have had an interbody fusion, and red is Smith-Peterson osteotomies. And again, the same holds true. The closer you are to the periphery, the more related you are to your cohort. And the opposite is true if you're towards the center, getting towards other clusters. And again, just a case statistic showing that 4 clusters is appropriate, is an appropriate way of displaying the differences in the surgery groups. And what we see here is just looking at the sample size, the osteotomy, the number of levels that were done, whether or not the pelvic was instrumented, interbody fusion, whether or not you went posterior versus anterior, and the type of osteotomy that was performed. And all these are statistically significant p-values to show a difference. And this graph right here is the real heart of the paper, where it pits the patient populations versus the surgery clusters, and it looks at their outcome measures, and most importantly, their complication rates. So we see the key down here. 1 is 3 column osteotomy, 2 is no osteotomy, no interbody, 3 is an interbody, and 4 is a Smith-Peterson osteotomy. We know a 3 column osteotomy is the most invasive of the lot. So it's no surprise that it has a higher complication rate as opposed to doing no osteotomy, which here the complication rate is 0, but it's a small sample size, only 7 patients in the older vision population versus in the older vision population pitted against no osteotomies. And then we can see their outcome measures as well. So this is a way of talking to your patients, seeing what category they fall into, whether the young category, the old with no surgeries before, or old with previous surgery, and at least having an informed discussion with them about what their complication rate could be and their outcomes could be based on patients of similar characteristics undergoing a similar proposed procedure. Limitations of this study, retrospective in nature, and that has its own inherent biases. And even though there were about 570 patients in this model, if you're using a non-supervised hierarchical cluster, you actually need a lot more patients. But the benefit of this is you can keep adding data points into this, and the model will keep reorganizing itself in real time. Okay, so that brings us to future directions of spine surgery. artificial intelligence is the topic, but I really look at this as just augmented intelligence, right? These tools exist for humans. Without the human connection, they're just beautiful pieces of technology. Um, so it's really an augmentation of our intelligence. And Dr. Lenke is famous for using technology. Really, 3D printing is its own um, new form of technology that has been around for a while, but has made its appearance in the domain of surgery. And Dr. Linke's printed 3D models of spinal deformities, draped them sterilely, and he's brought them into the operating room, and he can reference the model in real time as he's performing his corrections. And, and I think that's just a great novel use of 3D printing. But going forward, you can have augmented reality overlays, like we see here with this. This is an advertisement for a company, but you can have a VR headset or an augmented reality headset, your reference frame, and you can place screws just by looking through this headset, never taking your eyes off the patient, and you're able to see the spine overlay. And so there's a few different companies that are doing this, and they have different reference arrays, and you can see different displays of the spine. That can be quite helpful if you're utilizing this. And robotic planning, we're lucky enough to have a robot here at Harborview, and you can use the robot to plan your screws. And this is becoming more and more popular. But this case right here with previous hardware and a previous Harrington rod really shows the utility of preoperative planning, or intraoperative planning, I should say, to where you can obtain a scan and plan your screws with respect to having previous instrumentation there, a lot of fusion mass that could distort your planning if you weren't using a robot, and really just line your rods up. We see with both of these plans here, one would be much easier. This would be much more difficult to rod as opposed to this plan here. So it can save you some time if you were able to plan your screws, especially when you're doing a revision surgery. I think that's where the utility of a robot really shines. Things like the UniD, which is a subsidiary of Medtronic, to where they can pre-bend a rod for you. You go on a website, they have a patient or a physician portal where you type in all your deformity parameters. You can plan your surgery with respect to what interbodies you want to use, how much lordosis you want to restore, and simulate the surgery you're going to do, and then create a rod that is then pre-bent and then sterilized and then sent to the hospital, and you can have it ready for surgery. And they argue that this saves on operating time. It also preserves the integrity of the rod because you're not bending it and putting notches in it. And that's at least what they purport. And then this also uses machine learning, because then these patients are followed post-operatively. And if there's any deviation from the plan, that's fed back into the machine. So it can learn from where the deviation is and give the surgeon a more informed plan and instrumentation. So these are patient-specific implantations, and a similar thing is being done for corpectomy cages in the cervical spine as well. So just this is getting towards the end of it, just a few philosophical musings. I think we've always had pooled intelligence, right? This is the utility of M&Ms. And if you can get over the anxiety and the stress that comes with an M&M, and the fact that a patient was harmed or lost their life from this, you can really glean a lot from those discussions. And I think we owe it to our patients. Yeah, sorry.
In my car and the
Sorry. Yeah, I think we owe it a lot to our patients in our field to learn from our mistakes and our mishaps. And we've always pooled our intelligence in some way. And this is the benefit of multidisciplinary conferences, right? I've been tuning into the spine conference, and one surgeon will notice one slice of an image, and then everyone else will see it and will say, oh, it'll be an aha moment. And that's the beauty of pooling our intelligence, which we've done since the beginning of medicine. I mean, just imagine if you had decades worth of the highlights, the lowlights, and everything in between of Dr. Ellenbogen's case, Dr. Shagar's cases, or Dr. Zhang's cases, and metrics that they not only they recognize at the human level, the 10, 20, 30 variables that they can log in their brain, but imagine all the things that they can't log, that the machines can log, and then it can crunch and then spit things out. We'd have a much more informed set of data to go off of. And attendings are great at this. The great attendings will always have almost like a Rolodex of complications in their head. And they'll want you to do something a certain way. And if time allows for it, they're able to explain the rationale behind why it's done a certain way because they've seen one complication, right? And that's enough to say, never again, I'm not doing this. And that's an event that can be logged and pooled, and everyone can learn from it, right? And we've been trying to do this in some way, but the machines are just better at creating a memory that's infallible. The human mind, it's beautiful in so many regards, but machines are just better at remembering and crunching things and seeing patterns that we just cannot see. And I believe that we're really headed towards a virtuous cycle in the field of neurosurgery. With respect to other surgical domains, I believe neurosurgery just keeps advancing at so many levels. The basis of this talk was spine surgery, but you can really have this discussion for virtually every subspecialty of neurosurgery. Vascular neurosurgery is taking off so much. I was fortunate enough at my residency program, it was very IR heavy. And it seems like every few months there's some new technique or some new device that's coming out. And that's just more data that's being fed into the system. And we're able to look at vascular lesions in a whole different way. You know, you can measure so much more aneurysm wall thickness and just so many more data points that were not available 30 years ago we have because of IR. And we have to think really, and you can apply that to virtually every domain. You could also make the argument that there's a diminishment of skills, right? Because not many aneurysms are being clipped nowadays. And that's probably a good thing, right? You're saving so many operative hours, so many craniotomy hours, a lot of morbidity and mortality from open surgery. But that being said, IR also creates its own set of morbidity and mortalities. But I think most vascular surgeons, open and endo, and everything in between would make the argument that it is better to treat something endovascularly if possible. But that being said, open surgery, I believe, will never go out of style, especially for ruptured aneurysms. You often need some form of decompression, and you want to be able to have the skills of clipping an aneurysm if needed. But with the advent of technology, these things could be diminished. Same thing with something it's not simple, but rod bending, right? It's not something we think of too often. But if you were to drop that custom-made rod, are you really going to wait an hour for it to be sterilized, or are you just going to, call on your skills of rod bending? And if you're at a busy trauma center, if you have a good workflow, you can use the robot in the intraoperative navigation and those things. But these patients are often sick, and if your technology is failing or your workflow is not up to par, you might not want to putz around with a robot or even O-arm. You'll have to revert to free handing or just fluoroscopy, right? So you'll always want to keep these skills up because the machines are great. They do so much for us. But we're still the surgeons, and we have to be in the driver's seat. And it's a poor carpenter if he blames his tools, right? You can't say the robot failed, so I couldn't do your surgery. I don't think that's excusable. You always want to be able to have every level from the most technologically advanced to the most basic level and be able to fall back on that when needed. And that puts a bit of a burden on all of us because we're all teachers, right? And lifelong learners at every level here, from medical students up to our seasoned attendings. We're all still learning and teaching to some degree. And the beautiful thing about neurosurgery is I don't think the old saying, an old dog cannot learn new tricks applies, because you'll see very seasoned attendings, very willing to use a robot or learn about some new IR procedure, even if they don't do IR. This is a field of people who just love learning. And with that, I think we also have some of the smartest patients because you have to have a high level of intelligence to really understand what's going on with your nervous system. And more patients are learning more and more about the pathologies that they have and getting second opinions, which I think is great because a more educated patient, I believe, allows for better outcomes. I think it's good when you can have the dialogue with your patients. Um, Clinic, I used to really love clinic when I was a junior resident. But clinic is so fun nowadays because you have great dialogue with patients and you can talk to them very candidly about their different options. And you can really have a great uh, partnership about the best way to treat the patient based on their lifestyle and their expectations for surgery. And it's really transforming the art of medicine. And the patient-physician relationship, I think, is the ultimate factor. And those goals that you put forth with your patient should be the ultimate deciding factor for the surgery you do. These machines and these models are great, but it's incumbent on the physician to really take hold of it and not let nefarious actors, such as insurance companies. I don't mean to denigrate any field, but we always want to be in the driver's seat when it comes to advocating for our patients. And AI and modeling is already being used against us in some way when we're advocating for patients and having those phone calls with insurance and talking to another physician who may or may not be our peer in our field. They're using these models to leverage data and looking at our outcomes and operative times and things like that. So it really is important for us to understand how these models work and push back and then use them for the benefit of our patients. And in summary, I think AI integration will be seamless. It'll follow the trajectory of electricity. It'll augment our intelligence, but definitely not replace us. Computer vision is beautiful, and that colonoscopy study is able to see almost as well as an endoscopist. But in terms of motor function, robots cannot do what our hands can do at this point. We're still the surgeons, we're still in the driver's seat. And our obligation, our ultimate obligation is to the welfare of our patients, period. And I think once we keep that at heart, we'll do the right thing. And the same way we use electricity for good and it just becomes a part of our life, I think AI will do the same thing for the field of medicine and neurosurgery. References I used along this discussion. And we can open up to any Q&A.
Great.
Yeah, Adrian, oops, I'm sorry.
No, go ahead, Christoph, it's for you. Go ahead, please.
No, I mean, I think I really enjoyed your talk, and I also like that you included so many other fields in your discussion. One thing, question I had for you is like, as you know, I mean, we know more about our endoscopic patients than anybody else. I mean, you have seen the clinic right now. I tell my patients what happens on day 3, happens on day 7, happens half a year afterwards. We have all the data. We have more than now almost 10 million data points on all these patients. Where do you see the value going forward right now? You talked about robots, you talked about clinic, you talked about decision making. Where do you think we see, the next big impact in our patient care using these models, given that we collect all these data points?
Yeah, no, it's a great question. And Spine Healthy has really opened my eyes about how patients do. I think it'll be just getting back to quality of life. Telling a patient you can have this surgery, this is the best surgery for you, but this is what you can expect. And I think setting the expectations for patients or just humans in general, once you know what to expect, you can prep for it better. And I think that's one of the nice things about our clinic is that we're able to have that discussion based on if you're going interlaminar or transforaminally, what they're going to be up against. So setting expectations and getting people back on their feet in a time frame that they can reference is ultimately what I think it'll come down to, because it's about mobility, right? Getting back to normal life, because they were normal before they met you, and hopefully they can get back to normal afterwards.
Do we have any other questions in the audience?
Great. Anybody?
AJ, maybe you also want to talk a little bit about, the utilization in the OR and about technique. I mean, you talked all about patient follow-up clinic. I mean, where do you see this technology helping us with our surgeries?
Well, in the endoscopic domain, how we decompress neural elements. You've been able to say, when I take this approach, or there's this amount of stenosis along the nerve root, or I do this amount of reaming, things like that. You have data points to where you can say this patient might have a core state where their numbers, their postoperative assessments look worse for a time, and then they get better. And it can inform you as to how aggressive you need to be in the OR. Maybe you can get away with, and not get away, but you can use the data to show that whether or not I do a very, very thorough decompression that manipulates neural elements a little more versus I'm a bit less aggressive on the neural elements and the outcomes are the same, that can inform the extent of your decompression as well. So that's one area that I see it having a role.
Any other questions in the audience? So what do you think that, just to finish up your last point, what do you think we should do as surgeons to kind of get ready for the new age and how, to really sort of put us at the right spot and also enable the best care for our patients? What do you think we have to do?
I think it's prudent for the surgeon to really invest the time, as painful as it may be, to learn about how these models are created and learn, one, how we can use them, and two, make sure they're not used against us, right? And that's from the machine learning perspective. And from a robotic and technology perspective, it's really take the time to learn how to use the machine. Because in the OR, we've seen how finicky the robot can be. It's a great, great piece of technology. But if you make one misstep with how much pressure you're putting on the patient, you can throw everything off. And then it goes from being a big help to being really a detriment to the patient. You can actually hurt the patient with the robot if the navigation is off. So it's utilizing the technology well in advance in the cadaver lab beforehand and taking the time to learn. And then really just being humble enough to embrace new technologies. I'm a little biased because I love endoscopic spine, but I really can't see how that is not the future. And it's a labor of love and it's difficult to learn, but just embracing these things instead of running away from them will be important.
Can I ask a question here just about sort of garbage in, garbage out type thing? All of these predictive models are based on the population data, the population from which the data came. Just to use an analogy, patients who don't have operations don't have pseudoarthroses. So when you're predicting pseudoarthroses, you don't have a population in there who didn't have surgery. And that isn't so important when you talk about correction, but it is important when you talk about patient outcomes. So the patient that comes to clinic and you don't recommend surgery, now they may go somewhere else and have surgery or massage or something, but you lose that patient. The patient isn't in the database. And that could very subtly, as everyone is incredibly impressed with AI, could very subtly influence the direction in which we go if we're not careful to specify our databases and understand the limits of our generalizability.
Yeah, no, that's a great point. You're right. We're missing a lot of data by the patients from the patients who don't have surgery, and we can go on to see their outcomes from not having surgery. Yeah, no, that's a very fair point. Okay, no, I
Well,
feel a bit early.
thank you, AJ. Thank you. Really appreciate you giving a talk, stimulating talk so early in your fellowship. And good luck with your fellowship. And everybody have a wonderful week.
Yeah. Thank you, Dr. Ella Bogan. Thank you all. A pleasure.
Bye bye.